Good evening to all. Thank you so much, APR family. So, I am going to discuss about few cases of neurology. So, starting with case 1. So, we have 32-year-old male patient with nil comorbidity. He was symptomatic since 2 years. So, he had generalized involuntary movement of all four limbs, more on right side, and difficulty in speaking with occasional tongue bite. So he had these symptoms since 2 years, and his symptoms were worsened since last 3 weeks. So he came for consultation. So he had no slowness of movement, no cognitive impairment, no seizure or no behavior symptoms. Her family history was not significant, personal history was also not significant, and past history was also not significant. On examination, he was awake, alert, speech was normal, pupil was equal, no facial asymmetry. He has involuntary movement in the form, poriform movement involving tongue and all limbs. There was no rigidity, bradykinesia, power was okay. Left and reflexes over plantar flexion, no cerebral sign, and sensation was also okay. So this was his first video. Since a while walking, he has poriform located limb. Involuntary movement involving and this video. In the lower limb also. So basically, he had chorea, which was going on since last 3 months, and her symptom recently worsened. If you see the approach of the chorea, so basically two causes, genetic causes and non-genetic causes. So this patient has no any family history. So basically we focus on non-genetic causes. If we see the etiology, there are structural etiology, infectious, parainfectious, autoimmune and paraneoplastic, metabolic and endocrine etiology, electrolyte disturbance, hematological, drug-induced chorea, and some other like post-cardiac arrest or sometimes functional also. If we see the initial workup with patient of chorea, particularly adult patient, so there list of like CBC, metabolic profile, thyroid, ESR, autoimmune causes, infectious HIV, vitamin, and in case of female pregnancy test, celluloplasmin, autoimmune encephalitis panel if onset is less than 1 year, and to rule out structural cause, MRI brain. So we have evaluated this patient. So her routine biochemical parameters were normal. CBC, electrolyte, LFT, ESR was 35, celluloplasmin was normal, SO titer was normal, TSH, HIV all come with normal limit, 2D was also normal, and MRI brain was also normal. So after this, this patient has no any family history, so we investigated further and sent us autoimmune workup. So we sent her his ANA, which came 4 plus positive, and his beta 2 glycoprotein was also high. IgM, IgG both were high, and the cardiolipin antibody was also significantly high, and her SSA and SSB came strong positive. So basically, this patient had a generalized coliform disorder secondary to the Sjogren patient. Sjogren syndrome in a male patient. Generally, we see Sjogren in a female patient, but it's a very rare cause. So he was started on immunosuppression. We have given 6 cycles of cyclophosphamide, 15 milligram per kg, and after that we put him on umnacotin, mycophenolate, and is sick. So he was his treatment was significantly improved. you can say, it's become completely normal. So after 2 months of mycophenolate therapy, he had again relapsed. So we put him on the rituximab. So given 2 gram induction pill followed by the 1 gram every 6 months. So currently he is on rituximab and he is absolutely doing well. He had taken 2 cycles of rituximab so far. If you see, Sjogren is a multi-system disorder. It has peripheral as well as central neurological manifestations. It causes neuropathy like axonal, sensory neuropathy, motor neuropathy, small fiber neuropathy, trigeminal, and also affect trigeminal and other nerve. It can also cause autonomic neuropathy and demyelinating polyradicular neuropathy. In the central causes can cause everything: seizure, movement disorder, cerebral syndrome, optic neuritis, motor and sensory loss, multifocal disorder, and also it can affect spinal cord also. It can cause progressive myelopathy, neurogenic bladder, acute transverse myelitis, and there are also some case report also present as a coliform disorder. So coming to case 2, 33-year-old gentleman. He was diabetic since 2018. So he was symptomatic since 2018-19. He has also involuntary movement involving the limb, trunk and neck, and he had difficulty in walking due to the same. He also has some nocturnal involuntary movement without awareness, and there were no specific trigger. So this was his video. You can say upper limb, lower limb. So while walking, also he has generalized coliform movement, and he has also difficulty in walking due to the. So similar type of the movement as previous case. He had history of RTA in 2018, and in families, grandfather has diabetes too. But we asked in further detail. So he said his mother, maternal uncle, aunties, and maternal cousin all have similar illness. So here we have a strong family history. The earlier case it was not there. So we directly go for the genetic testing, and we send her his Huntington's for CAG repeat for Huntington's disease, and it came out to be positive. So it was number of CAG repeats 51. Normally we take cutoff around 35. And after 35, depending upon the half penetration or full penetration, CAG repeat came positive. So we have started him on the tetrabenazine, Revocon, and we did he is doing well. Case 3, 19-year-old male with no comorbidity. So in the March 2015, he had developed the inability to speak and swallow, and on examination he was aphasic and had palatal paresis. So this was his MRI of March 2015. You can say it is a multifocal peripheral enhancing lesion involving the subcortical region of the cerebral hemisphere with peripheral diffusion districts. Same region in the flare. So this is basically a demyelinating lesion involving the bilateral cerebral hemisphere. So he was evaluated at them in the 2015. CSF was normal. Limited investigation was available with the patient. ESR was 6, CRP 9. So he had received oral steroid for 6 weeks and he improved. So then goes to follow. In January 2017, he developed blurring of vision in the right eye. So again, let's say in the multifocal region involving the bilateral, frontal, parietal region, and it also has the right side optic nerve. If you can see, this was optic nerve. It is enhancing on the right side. So also second time we improve with steroid. So in the November 2023, at that time we admitted with the acute febrile illness with whole level retention. So at that time I have seen patient first time. So in examination he was awake alert. There is impaired complex comprehension. And pupil was equal, but in the right side there was RAPD was there. In the power, he had almost quadriparesis. DTR was brisker, and he has bilateral unsustained ankle close. So we repeated his MRI. You can say there is large tube-effective type demyelinating lesion in the frontal region. Also going extreme in the parietal lobes. It was very large. In the cord, if you can see, there is a signal also in the cord from the cervical dorsal line. So we explained him and we evaluated. For CSF routine micro, the protein was 123. It was on higher side. Sugar was 110 with corresponding blood sugar 123. Cell was 6. CSF polycomponent brain was negative. Triple H was negative. ANA was also negative. We also sent in NMO and MOG antibody level considering relapsing remitting demyelinating lesion. It was also come negative. So we gave him 5 days IV methylprednisolone. So with that he was significantly improved. At the time of discharge he was walking. And we started him on steroid sparing immunosuppression on azathioprine. So simultaneously steroid was also going on. So this event happened in the November 2023. In December 2023, he again came with the stool urinary incontinence and right lolling dragging. So we repeated his MRI. You can say there was new lesion in the bilateral parasagittal lobe with genuine body of splenium corpus callosum. So again he developed new lesion. At that time cord was normal. There was no new lesion in the cord. So we give him rituximab in the January 2024. He had received 2 gram IV rituximab, 1 gram every 15 days as per protocol. So after giving rituximab, we slowly taper steroid because generally rituximab take around 4 to 6 weeks to act. So we give oral tapering steroid for 4 to 6 weeks, then we do. So after that he was absolutely okay. So after 6 months of rituximab, we repeat his MRI plate. You can say all the lesions were vanished. Some residual is there. Cord is also. So he currently every 6 months he is receiving rituximab. With that he is doing very well. So unfortunately we have no clear-cut guideline till how long we have to give this, but based on the patient to patient we take decision. So till that he had received 3 doses of rituximab. Unfortunately we don't have diagnosis here because all the workup came negative and because of the financial issue we did not give extensive evaluation. But since he is doing very well with the rituximab, we decided to continue with the rituximab therapy. Case 4. So 19-year young female with normal birth and developmental history. So in the January 2019, she had right-sided hemiparesis. So she was improved with the treatment. And again in the October 2025, he developed with holocranial headache and with seizure, left upper limb sensory focal seizure followed by secondary general headaches. So I have seen this patient in October, and on examination wise, she was okay, except there was mild left hemiparesis and DTR was for brisker side and plantar were legs. And this was her MRI plate. You can say there is a large lesion involving the bilateral cerebral cortex. So again, it was like a demyelinating lesion only. So we evaluated her. Routine investigation was normal. CSF saw elevated protein with 15 cell and all were lymphocyte. ANA was normal. And nowadays we are seeing more this type of patient, like young patient came with headache, and we found this type of demyelinating lesion. So we also evaluated and we found that we send is NMO and MOG antibody level. So that NMO MOG antibody titer become significantly positive. Is more than 1:2560 titer was there. So it was the MOG related demyelination. So we give her IV methylprednisolone for 5 days followed by oral steroid. Currently she is on steroid bearing immunosuppression, azathioprine and anti-seizure medication. So on last 2 months she is doing well. So we will decide about should give rituximab based on the how she respond to this medicine. So the important thing is this: generally we consider demyelinate as a white matter disorder, but she had a seizure. We generally rarely see seizure in a demyelinating disease. But now they have said that this disorder is no longer limited to the white matter. They also involve the grey matter also. So because of that, I think we have seizure. Okay. Thank you.